So, hi everyone, my name is Gaurav Kumar and currently I am pursuing Masters in Public Health in Health Economics and Finance. So, today is second day of making video for YouTube and I want to especially mention to my friend Ravi who has motivated me a lot for doing this. So, a special thanks to him. Now, today I will be discussing the paradox of urban healthcare in India, access without equity. So, when we think of cities, we assume better healthcare, more hospitals, more doctors, better infrastructure. But here is the paradox: urban India has the highest concentration of healthcare resources, yet some of the worst health inequities. So the real question is not whether healthcare exists in cities, but who actually has access to it. So friends, right now I am doing my urban internship in a mist ward of Mumbai, and there every day I am visiting that area, and situation is worse. People are staying there. Like when I ask them that from how many years you are staying here, they reply that we are staying here from last 15 years 20 years, and still they are not aware about basic health availability from the government supply side. So there is lots of preventive policies are made from the government, but that has not been accessed by the public. So where is the gap? So the real question rises here, that we usually presume that there is a lots of spending on health in cities. There is lots of hospital, but still there is a public health issue uh, are there in cities. So where is the gap? Who actually has access to it? So in this video I will analyze urban healthcare in India through three structural dimensions. First one is inequality in access and utilization. Second one is dominance of the private sector, and third one is weakness of primary healthcare systems. So the central argument is going to be of this video is urban healthcare in India is characterized by availability without accessibility and growth without equity. So urban areas are often treated as homogeneous, but in reality they are deeply stratified. At one end we have high income population accessing corporate hospital, at the other millions live in informal settlements with limited or no access to basic healthcare. Or and the prime example is the city in which currently I am staying, Mumbai. So when you will visit Mumbai, you will see that there is completely paradox of high rise between high rise building and slums just beside her. So I think person who is staying in that high rise building, they have too much high capita expenditure, and person who is staying in slum besides that high rise building have lowest per capita expenditure in India. So when you will visit, you will observe that city is beautiful, that but behind that beautiful city there is lots of struggle and lots of pain is there. So if you want to feel that, you should visit that slum also. So yes, I was there, that at the other end millions live in informal settlements with limited or no access to basic health care. If we see NSSO survey or NFHS survey, then data clearly shows that urban poor population often delay or avoid treatment due to cost. Preventive care utilization remains low among slum population. So cities like Mumbai and Delhi illustrate this contrast vividly. World-class hospital exist alongside densely populated slums with inadequate public health services. So while healthcare infrastructure is geographically concentrated in cities. Access is, access is socially and economically unequal. Now, the second defining feature of urban healthcare is the dominance of the private sector. A large proportion of outpatient and inpatient care is in urban India is delivered by private providers. This includes everything from small clinics to large corporate hospital chains. While private providers increase availability, they also introduce key challenges like high out of pocket expenditure, lack of price regulation, variable quality of care. So, for the general public, I want to explain what outpatient and inpatient. Outpatient is person who come in hospital for OPD services, like there is no need of staying there, so they are known as outpatient. And inpatient person who have to stay there in hospital for the further treatment, so such type of patients are called inpatients. What is a high out of pocket expenditure? So there is a criteria from the economist that if a person who is spending more than 20% of their annual income on health, or on the services except food and other needs related to health, that is called high out of pocket expenditure. Lack of price regulation. So when you visit a shop, a medical shop, and in the same cities, even in your same locality, you will see that there is a price variation, and that exists because we don't have a strict regulatory law. There is a price regulatory body, but you know that how government works. So I don't think uh, I should say much about this. You all face every day. Variable quality of care. Even government schemes like Pradhan Mantri Jan Arogya Yojana aim to improve financial protection, but their impact in urban areas is uneven due to limited awareness, supply side constraint, selective participation of private hospitals. This creates a system where access depends heavily on the ability to pay rather than need. Now, the third issue is the relative neglect of primary health care in urban areas. Urban health systems are disproportionately focused on tertiary care, a specialized hospital, and advanced treatments, while primary care remains fragmented and underdeveloped. Programs like NUHM, National Urban Health Mission, were designed to address this gap, particularly for the urban poor. However, implementation challenges persist. Shortage of urban primary health centers, inadequate human resources, weak referral system. As a result, even minor health conditions often lead to hospital visits, increasing both cost and system of burden. From a health system perspective, this reflects a failure of gatekeeping and care continuity. In addition to a structural issue, there are some uh, emerging health challenges like rising burden of non-communicable disease like hypertension and type 2 diabetes, environmental health risks including air pollution, mental health concerns linked to urban stress and isolation. These challenges require integrated preventive and community-based approaches which current systems are not adequately designed to deliver. To conclude, urban healthcare in India presents a paradox: high availability of services, but unequal access and financial barrier. A strong private sector presence, but weak public health foundation. So, policy responses must focus on strengthening urban primary health care, regulating private sector practices, expanding financial protection mechanism, addressing social determinants of health. Because ultimately the goal is not just to build more hospital, but to create a system that is equitable, accessible, and preventive in nature. Thank you. So, friends, even when we visit hospitals like JJ or uh, Amani hospitals, or there is a hospital in Govandi West, Satabdi Hospital. You will see that person who is visiting private hospital, they have highest per capita. They are belonging to top 5 to 10% of the public in India. But when you visit Satabdi, you see that crowd for the basic treatment, and they are not getting that treatment. Why? Because of lack of human resources, because of lack of funding from the government side. Even government are spending on basic health facilities, but public are not getting the benefits of that, because there is a lack in system, because of the trust gap which is lacking in the person who is running that system. So if we want to have a healthy healthcare system, so we have to we have when we go for that services, we should be doing that work with the integrity, so that person who is visiting that hospital with the hope that they will get the basic facilities, they will get the treatment. So I think they deserve this, so we should do our work with the integrity. Thank you very much.